So welcome everyone. We are so excited to talk about this topic today, having the birth that you want, how to make a birth plan. We have some guest speakers here. This is Gentry, say hi. We have baby Maris in here that's come, and then baby Nick over there. So if y'all hear some squeaks from them, just ignore that. She may have some thoughts too on the topic.
Gentry wants to teach the class.
Okay. So you'll see in front of you, you have our birth plan that we have on our website. Do you have to have this particular birth plan? No, but it's a good guide to get your mind kind of thinking about what are some of the things I might want in labor, and what are some things I might want after I have my baby. So that's there in front of you. So first off, what is a birth plan? So a birth plan lays out things that ideally in a perfect world, how you would want to see your birth. It can help you feel supported during labor if those things kind of are things that can happen for you. It can help your support person help talk about those things so that when you're in labor, your support person can know what's happening and kind of have a plan as well. Really importantly, it also gives your medical team an idea of those things that you have in your head, so that we know how to support you best as well. So we really want to know about those ideas that you have for your labor so that we can accommodate them as close as possible. Another thing about a birth plan is, of course, we want to know your ideal perfect world, what would happen in your labor, but also labor is unpredictable. We know that. So we want you to be able to think about those other things that could happen if your birth doesn't go exactly as you have planned. So you can think about those scenarios and have a plan for that as well. So it's kind of like a plan A and a plan B would make the perfect birth plan. So do you have to have a birth plan? No, you don't have to have a birth plan. If you decide, having it all written out isn't for me, we at least want you to have some thoughts in your head. That way when you come in and see us to have your beautiful baby, then we can kind of know what directions we and you want to go. Make sense? Okay, awesome. So the first thing I kind of want to point out is that TMH is the only baby-friendly accredited hospital in the region. So we're going to talk about kind of what that means. I'm going to have my friends back here kind of help me out with that. But I find that when people come in, they immediately say, oh, these are the things in my birth plan. And they start running down the list. Because we are baby-friendly and we have such a big push on helping moms and babies the best we can, I find that a lot of times those things that are on your birth plan, we're going to automatically do. So in this next little section of time, we're going to talk about what it means, us being baby-friendly accredited, and then those things that we're going to automatically do. If you find that you don't want those things, you need to let us know. But this is what you would expect us to do on every single occasion, okay? So I'm going to let Carmen kind of take over that.
Okay. We're really informal, and so if y'all have questions, we are going to have a question and answer at the end, but just feel free to ask. Like Joanna said, please tell us if you do not want the next 4 things that we're going to talk about, especially skin to skin, because our automatic reaction is just to throw that baby right up on your chest without even kind of asking questions. And some people are like, oh, I didn't really want that. Okay. So just let us know. But skin to skin is the first thing. So after delivery, when the baby comes out, if you're having a vaginal delivery, so we're going to talk about kind of 3 scenarios: vaginal delivery, C-section, and then what if your baby needs a little bit of extra support? Maybe it's, we say, not wanting to do life. So that's the quote unquote what we say. But so we're going to talk about those 3 scenarios real quick. So skin to skin in a vaginal delivery. As soon as the baby comes out, what we do is we want to take that baby right to your chest, okay? The reason skin to skin is important is it helps regulate temperature, it helps regulate blood sugars, it helps with bonding. If you are going to breastfeed, it helps promote breastfeeding. Really cool thing is they put their scent there, and then when they go away, when you hold that baby again, they're like, oh, I've been here before. This is familiar. I know this place. I know this person. They can hear your heartbeat. They can hear the sounds that your body makes that they're used to hearing on the inside. They can then still hear them on the outside, so it helps calm them down, kind of thing. So skin to skin is really important for a lot of different reasons. So in the vaginal space, as soon as you deliver, baby comes out crying, doing life, we're going to take that baby right up to your chest, dry it off, and start that skin to skin process, okay? Y'all ignore my shortness of breath. Y'all all can sympathize with me. Baby will stay skin to skin for at least an hour, okay? Or until after if you're gonna breastfeed, we want that baby to skin for an hour or after that first feed, okay? If you're like, I'm done with this, I need a break, you can ask for the baby to be moved, taken off, or if you want a little bit of extra time too, that's fine as well. There are some things that we like to get done to the babies, but just communicate that with your nurse, okay? What does it look like in a C-section delivery? It's a little bit different in the OR. We try really hard to do skin to skin in the OR if that's something that you want, but I will say there are some constraints. Number one, we're working with this tiny little space from like here to here that's not sterile, right? Because they're down there doing their thing. And so it just gives very little room to hold a baby skin to skin without breaking sterility. Make sense? So we can do it. It is possible. It's just a little bit hard. Another thing is that in the OR, moms tend to be a little bit more, you think, I don't want to do skin to skin, and then it's kind of like I'm queasy, I'm tired, my adrenaline's coming down, I just had this baby. And sometimes moms don't feel quite as great to hold the baby right away in the OR, and that's fine too. And what we do in those cases, if you can't do skin to skin or don't want to do skin to skin in the OR, it's fine. When your support person goes to the PACU, what we do is a lot of times we can start skin to skin with the support person in the PACU. And as soon as you get to the OR, we're going to put your baby skin to skin. As soon as you get to the PACU from the OR, we're going to put your baby skin to skin. And then we're going to start that whole hour process just like in the vaginal space. Does that make sense? If your baby's misbehaving, they do that. Term, healthy, no problem steering your labor. Sometimes they just misbehave, and that's okay. Life is hard, right? So sometimes they need a little bit of help. So if the baby comes out and your baby's not like vigorous crying, we will take the baby to the warmer in your bed, in your room, okay? We don't take your baby away from you. So in the room, take the baby over to the warmer, dry and stimulate the baby. A lot of times that's all it needs. And then we come back skin to skin, okay? If the baby needs to go to the NICU, because it's really misbehaving, no, I'm just kidding. Over in the NICU, they do what we call kangaroo care. So they want that baby skin to skin too, as soon as we can get it skin to skin. Now, if you've had like a micro preemie or one that's a little bit touch and go, we have even a cool program where they'll give you a fabric cart and you will carry that fabric cart, get your scent on it, and then you can leave that baby, that heart with the baby. You'll take it back with you and rotate them in and out so that baby has your scent. So that's a form of skin to skin while you can't do skin to skin. Does that make sense? Any questions about skin to skin right now? So please tell your nurses if you don't want to do it. Please.
Because you're going to get it.
You're going to get it anyway.
Actually happen.
All right, I'm going to turn it over and let someone talk about delayed bathing.
Okay, delayed baths. When I first started nursing, the first thing they did was you had your baby, they took it to the nursery, and they did a bath. Well, now they have learned that temperature regulation and blood sugar regulation is very important for these babies. So we like to do delayed baths. It's delayed for up to 24 hours after birth. I feel like sometimes I'll do it a little bit before then. So just know that, we can wipe your baby off, we can get your baby wrapped up and cleaned and all that, but we try really hard to delay those baths for a little bit. The vernix that is on a baby, sometimes around 37 weeks is when it starts kind of breaking down a little bit. It helps keep the baby's skin moisturized and soft.
That's that cheesy white stuff. It's like the world's best moisturizer.
Yeah.
And antibacterial component.
Yeah. So you might see a lot of that on your baby, depending on when you deliver gestation-wise. There might be a lot, there might be a little bit, but that will help your baby stay moisturized and protect the baby's skin, okay? Breastfeeding rates, of course, if you want to breastfeed, not having the baby go and get their first bath until the first 24 hours helps promote that bonding and helps keep that baby with you skin to skin. So we try our best to delay it as much as we can. There are certain instances where they will have to bathe the baby within the first 4 hours, but typically it's more of an infection prevention thing. So your nurse will definitely communicate that with you if that needs to happen, okay?
Cool.
You want to do breastfeeding?
We can talk some breastfeeding. So part of Baby Friendly is obviously promoting breastfeeding, okay?
I want to make it very clear, you do not have to breastfeed. If you decide that that's not what you want to do, that is a-okay. You just communicate that with us and let us know, okay? We really want to make sure that you have the birth experience that you want, and you know, you're here having your sweet little precious bundle of joy. So we really want it to be everything that you want it to be and everything that you envision that it's going to be, okay? So we do a lot of breastfeeding education. If you want to breastfeed, we're going to support you in that in every way that we can. All of our staff are very well versed and educated. We have around the clock lactation consultants who will be doing a breakout session after us. But they are absolutely wonderful. They are at our fingertips, an excellent resource to use during your stay here. They will come down to labor and delivery if we need help before you even go upstairs to the family care unit. And then we'll make rounds and help you and support you as best they can whenever you're up there. So we have an excellent team here. You guys will definitely get everything that you need if that's something that you want to do, okay?
But again, it's also important to know it's okay if you don't breastfeed. It's a hard thing to do. It's hard to, first-time moms. I mean, Joanna, she's a pro at breastfeeding, but I was not a pro at breastfeeding. So just communicate with your nurse what it is that you want, because again, we want you to have what you want. Okay.
Okay, the last thing that makes baby friendly kind of special is our rooming in policy. So our babies stay with our mamas. We don't even, like in labor and delivery, we don't even have a nursery to take the baby to. The baby literally stays in your room. Everything is done at your bedside. We find that it's really important to have families involved in those first few moments with the baby. Once you go up to our family care unit, again, the baby stays with you the whole time. If you are wanting to breastfeed, learning those little cues that the baby will do when the baby's hungry, you'll pick up on those little cues and you're like, oh, baby's starting to get hungry before the baby is frantically, I'm starving, mama, feed me, feed me. So that's really nice with the rooming in, is it kind of gives you that time to pick up those cues. And you're getting to know your baby, you're bonding. You're not, used to years and years ago, you'd go home after a baby's been in the nursery the whole time and then you're like, what do I do with this baby? It really helps you get to know your baby, bond with your baby, and then kind of gives you some extra knowledge for when you get to take this little nugget home. Cool? All right, so we've talked about baby friendly. Those are the 4 things that you're gonna get no matter what, okay? So now let's get into the fun stuff. Let's get into what you're gonna expect in labor and delivery.
Options.
Options.
The things. Okay, so the big thing about labor and delivery is, what are you coming to labor and delivery for? What kind of labor are you gonna have, okay? So when we talk about labor, you talk about inductions versus natural labor or vaginal, like natural, not vaginal deliveries, but like naturally going into labor on your own, okay? So those are the 2 types of, we're going to talk about vaginal deliveries first, okay? And then we're going to talk about C-sections in a minute. But those are the 2 types of like expectations when you come into labor and delivery and you're going to have a vaginal delivery. You're either going to come in natural labor, meaning your body's doing it on your own, or you're going to be an induction kind of thing, okay? If you are an induction, and there's 2 types of those. There's a medical induction and then an elective induction, okay? So what type of induction you are, or whether or not you come in natural labor, it all kind of looks a little bit different, right? And so people don't really know what to expect. So we wanted to kind of talk about that for just a few minutes, so that way you're not like completely blown away by, well, I came in thinking I was going to have a baby today, and well, that's not really the case if you're a first-time mom being induced, okay? So let's talk about a couple things about inductions. So the first thing is the type of induction, whether or not you're having an elective or medical induction. Either way, you may come in for what we call cervical ripening. And I'm telling you all of this because I want you to know that you're not going to most likely have your baby the same day you come in for a cervical ripening induction, and that's okay and that's normal. Be patient and to be expected, and bear with us, and your provider might not communicate that with you clearly. That's what we're here for, okay? We're the real people. Okay, so when you're having a ripening, like a cervical ripening induction, okay, there's different types. You might have heard of Cervidil or Cytotec a Cook's balloon. There's even something called dilapam. There's different options. But what it is to ripen your cervix. So this is an example of a cervix. I like to give the analogy of Play-Doh, like a can of Play-Doh that you've left the lid off of, right? It's been left off for quite a few days, right? That's what this feels like. Play-Doh that you can't play with, okay? This means it's not going to do what we need it to do in labor. This cervix right here is not going to open up like we want it to, right? When you have a cervix like this, not so much that it's opened up, but more so that, see how thin this is right here? It's nice and bushy and stretchy. That is what a ripened cervix looks like, okay? Not so much that it's opened up this big, but more so that it's thin and it's nice and mushy. This is your new can of Play-Doh. I can mold this into whatever I want it to be, okay? So when you come in for a cervical ripening induction, what we're trying to do is make your cervix look like this, go from this to something more like this. Not so much opened, but thin and soft, okay? So that takes time, unfortunately, especially first-time mamas, especially if you're having to be induced, maybe you have high blood pressure, you're a first-time mom and you're 37 weeks. Girl, you better pack your bags and hang on, and we're going to be friends by the end of it because you're going to be here for a minute, and that's okay, all right? Expectations, what to expect. That's what we want to talk about. So that's the difference in these two. Now, once we get you to this, that's when we can start that medicine that everybody talks about, Pitocin, right? The Pitocin medicine. Pitocin is a natural hormone that we make in our bodies, right? We make oxytocin or Pitocin ourselves. We make oxytocin. Pitocin is the manufactured kind. But same. We make it ourselves. It's nothing to be scared of. Everybody like, oh my gosh, I don't want Pitocin. Yeah, there are risk factors for it. But if you have to be induced and there is indications for using it, it's not as scary as what people make it out to be, okay? It's a very controlled drug. We give it in a controlled manner, increasing it kind of deal. What is different is it's just that it's not your body making it, so it kind of comes in at different increments. Everybody's like, a pit induction, so much worse. Well, a lot of that has to do not so much with the Pitocin, but the hormones that your body makes in different types of labor. Does that make sense? So yeah, it can be a little bit harder to cope with the contractions of Pitocin, but it's not that they're stronger, it's that your body has a harder time coping with them. Does that make sense? Okay, that's a whole nother tangent, but let's get back to Pitocin. So what Pitocin does is, now that we have this nice mushy cervix, Pitocin helps your uterus contract. We're gonna push that baby's head down. That baby's head is then gonna help open up this cervix, okay? So those mechanical ripeners are not to make you dilate, they're to thin you out, and then that Pitocin is what's gonna start helping that baby's head come down and helping that baby to come through and actually dilate the cervix, okay?
Makes sense.
Does that make sense? Once you get on Pitocin, things tend to speed up a little bit. Not always, not like you're gonna go from 0 to 60 in no time, but once you get on Pitocin, that is usually when things get a little more active, okay? Let's see. Now,
And sometimes you may come in as a Pitocin induction.
yeah. If you come in with that nice,
The good
favorable
Soft, thin
cervix,
cervix.
you may not need all of those mechanical cervical ripening medicines in the first place. Just depends on who
What
you
your
are
body's
and what
doing.
gestation you are and all the things that it's crazy our bodies do, right?
Mm-hmm.
Now, the next thing that we want to talk about, which is part of coming in labor, is sometimes you'll come in labor and all of a sudden then things just peter out and go away, right? Or sometimes your water will break and nothing happens. Well, what do we do then? Well, there's, that's what we call augmentation of labor. Like, you've started labor, but now you need a little bit of help, okay? So if you come in and you're ruptured and you're not laboring, usually we give you a little bit of time, and you can advocate for yourself to have a little bit of time. But at some point in time, there comes a point in time where risk of infection versus having a baby starts kicking in, okay? And that's a conversation that you and your provider need to have, okay? When we get to that point, usually And there's not a 24-hour mark, like when people used to be scared and you had to have your baby at 24 hours. That's not necessarily the case anymore. But around that point, things do increase for risk of infection, okay? So if you are ruptured and you're not contracting, what they'll do is usually start you on Pitocin, okay? Now, if you are, say you came in and you were laboring and then all of a sudden things just went away, there are options for that as well. And on your birth plan, it will say like, I don't want to be artificially ruptured, okay? So this is a scenario where you need to talk to your provider about if you are stalled out, that is an option that they can do if you're willing to do it, or you can have Pitocin started versus AROM. Different providers do different things for different patients. So that's a conversation that you would need to have with your provider, okay? So like if you've stalled out, say you're like 6 centimeters, you're not doing anything, what's the best choice for you? Is it Pitocin or is it breaking your water? And that's a conversation, like I said, to have with your provider, okay? But just to let you know that sometimes that does happen. And we get in this circumstance and we're like, okay, what do we need to do? We need to not speed this along, but we need to get things started back again, okay? Mm-hmm. So that's kind of the types of medical inductions that we do. Any questions about any of that kind of thing?
All right, now let's talk about what happens when you just come in labor, right? You're ripping and roaring. What would you expect? What are some of the things that you may see when you come in? So if I'm coming in rip roaring in labor, the first thing that we're going to talk about is IVs. So we highly recommend at least having a saline lock. That's just in case an emergency situation kind of thing happens, okay? So you can talk with your nurse about that. A lot of times what we'll do is we'll put a saline lock in where you just have IV access, but you can be up, you can be moving, you can do all the types of things. You want to get in the tub, go for it, no problem. If you need medication, some people need antibiotics while they're in labor. We'll hook those antibiotics up. You'll get your quick 30-minute infusion. You're unhooked and you're off to the races again, doing whatever you want to do. So that is something that you will definitely come in contact with is the IV.
Cecilia gives a really good analogy, I think, of...
So Dr. Bricklers, who taught this to me years ago, but it's quite simple, is that would you want to put your seatbelt on after you get into a car accident, or would you put your seatbelt on before you start driving? So kind of the same kind of idea with an IV in place. You know, a lot of people come in and they're like, I don't want an IV. But whenever we sit down and we actually talk about the reasons that we need an IV in place, most patients are like, you know what, okay, yeah, go ahead and put it on. Because in the event of an emergency, one of the things that you don't want us to have to do is try to find a vein to be able to put an IV in. If things are happening and it's that much of an emergency, then it's going to be very difficult to do. And why even do that? Like, let's just go ahead and have that line in place. Like Joanna said, we don't have to put anything in it whatsoever. Just have it. We are really good at not putting them, we put them in a place that is like convenient. We can put them up in your arm. We'll put them wherever you want us to put it.
We can wrap
honestly.
it. You don't have to see it.
You don't have to look at it.
Like Joanna said, you can still get in the tub.
Just
all of those kind of things.
Yes.
Put your seatbelt on.
And one thing to mention is that it's not only for you, but also there's things that we can do to help resuscitate your baby. So maybe your baby's not looking great. We can give it a little bit of fluids, those kind of things. So it's not just we're looking out for you, but also looking out in case your baby misbehaves as well. An IV is a form of resuscitation for your baby while it's in your belly.
Correct.
Yep.
Yeah, good point. Okay, let's talk monitoring. So some people think, okay, I'm going to come in to have this baby and I'm going to be strapped to the bed, and I don't want to do that. That is old school. We do not do that, okay? If you want to get up and move, do it. We have lots of different options for that. Some, depending on your circumstance, sometimes you have to be continuously monitored, meaning monitored all the time, and sometimes it's just intermittent monitoring. So monitor a little bit now, then you get a break from the monitor and monitor a little bit later. So those all are specific to the patient's situation, right? We have really cool monitors that we're super excited about. They're called the Novi monitors.
I wish I would have brought a sticker.
Yeah, so they are literally stickers that we stick on your belly.
3 of them.
Yep.
It would be like 1, 2, 3.
And you want to stand on your head, go for it. You want to get in the tub, go for it. You want to walk in the hallways, go for it. We can still monitor your baby. We can still monitor your contractions. They are awesome. We just
very,
recently
very
got
nice.
them, and I had them whenever I had her, and I could do whatever I wanted to do, and it was fantastic. So she was still safe, and I was still able to stand on my head if I wanted to. So labor support tools. You want to talk about that next?
Let's talk about labor support tools next. If you are being induced, if you are on Pitocin, you do have to be continuous monitored, point blank. There is no other option. Sorry.
But it doesn't have to be.
But it doesn't have to be you
you're
tied
down
in
to
the bed, all of that kind of stuff, okay? We can still get up, move around, all of those kind of things. But that is the one definite, true standard of practice in labor and delivery is if you're on Pitocin, you have to be monitored, kind of thing.
Yep.
Yeah, go ahead.
Those monitors are like the stickers, but are they like connected?
No, it's
No,
got a
girl.
little
a
blue
little
pod.
pod,
I
little
should have brought
battery.
one. I'm sorry, y'all. I didn't think about it. It's a little blue pod. It works by Bluetooth. So you put these sticky things on there, and there's this clear little box on the middle of it. You take this little blue pod, magnet sticks to this little clear receiver, and then you do your thing. You can get in the tub with them. You can get in the shower with them. That kind of thing.
No
Great.
cords.
No
Yep,
cords.
no cords.
whatsoever.
Yeah.
Yeah.
So it's super nice for people that want to get up and move around, kind of deal. We have 7 or 9 of them on our unit at one point in time too. So like we use them. We love them all the time.
Religiously.
Okay, so things to help support your labor. This is if you have an epidural or not have an epidural, okay? If you have Pitocin, if you don't have Pitocin, we have all these options for you, okay? So the
Everybody knows this one. Everybody knows
Yeah.
birth and balls. These are boring.
Y'all know
I'm
that,
just
right?
kidding. They're not really boring. They're great. But we have them in different sizes. But we also have a lot of other cool things. So
Yeah.
Not
we're not going to
just
really
your standard
We're not going to
birth
really
and
talk
ball.
about the birth and ball a whole lot. We
Birth
have
and
it.
ball
You can
is-
use it. Let's
you're
talk
getting your
about the
server
bougie
deal.
options, okay?
Yeah.
okay, so this first thing we're going to talk about is the cub. Ta-da! Here it is. It's pretty cool. These are all different positions we can do with this ball. Why are we using this ball? Well, number one, to help you feel kind of better when you're through the contractions, yes. But another thing is I'm going to pull out my baby and my pelvis here. Here's your pelvis, and here's your baby trying to get through this pelvis, right? Sometimes if your baby is kind of wonky positioned,
Gentry was wonky
my
position.
little friend here was wonky. We want that baby ideally to be like this. This is the best, easiest position for that baby to come on through, okay? But sometimes our babies don't do exactly that. That's okay. We can use some of these tools to do that. So we might have our baby in here wonky like my friend Gentry was, see? And then we can get this cub ball, and maybe mama leans over kind of like this one.
This is probably the most common use of the cub ball, I'm not going to lie. The one where she's in the bed with it, that one you can do, especially like if you have an epidural and it's really hard to hold yourself up. That one is great position to get you off of your back when you have an
Epidural
epidural.
patients love
And
using
so
the cup ball for
wonky
that.
Gentry will then, because I'm in a good position, then she gets in that good position to make my labor and my pushing better. And then out she comes, right? Okay.
And all of our nurses are very well versed in spinning babies and putting you in these different positions, and they will be able to tell, oh, you know what, this Gentry here feels a little wonky in there, so we're going to flip you around and put you in some different positions and see if we can't get her into the correct position. So
We're
going to pull out all these tools.
in just a minute, you'll see all the different things that we can do too with some of the other stuff. But the whole point is we want you to be in a position that's comfortable. The cool thing about this one, when you're like this, if you have a baby and you're having a lot of back labor, that position is great to get that baby off your back. It helps where your support person or the nurses can help do some counter pressure or massage. Because even with an epidural, as great as they are, sometimes you don't get rid of that back labor, okay? And so that's a great position to help get that baby off your back and get you comfortable. So it's about making you comfortable, but it's also about making your baby get in a good position to come into this world.
Bless us.
God bless you, Gentry.
Nope, Patsy fell out. You do the next slide.
Next slide.
Peanut ball.
All the
peanut
things.
ball.
And our nurses find it very, they like a challenge and they like to get a baby to move. So we use the peanut balls a lot. These are just different positions. And we have all of these options here at TMH. So we have the squat bars, like this lady right here is doing in number 9. We have peanut balls, all different size peanut balls. And depending on where your baby is in the pelvis, depends on what position is great for you to be in, okay? So we will rotate through different positions depending on where your baby is in the pelvis. Do y'all mind just hitting the next slide? I mean, it's just more positions. But it just gives you an idea of different things you can do, different positions. A lot of times we'll do a version of the wine circuit. I call it rotisserie chicken. And that's just where I roll you. And we start on our back, and then we roll to our side, and then we roll to our belly, then we roll to the other side, and then we roll to our back, and then we roll to our side. And that's usually what I like to do, and that's kind of what the Levon circuit is, kind of Carmen's version of rotisserie chicken. So, and then push in, which we'll talk about a little bit in a minute. You don't have to push on your back. I will say advocate for yourself, because providers, a lot of times they just get stuck in a rut and they want to do what is easy and common. But if you ask or you say, I don't want to, I have not had a provider ever be like, nah, babe, you got to get on your back. We got to push this way. So they are very willing and will let you do it. But you do have to advocate, talk to your nurse so your nurse can advocate for you.
The nurses will step in and say, this is what we're doing.
Yeah, if you say, I don't want to push on my back, and you tell your nurse, then your nurse will stand up they'll advocate for you. It's not that the doctors don't want you to push in different positions.
It's not something that they think about, honestly.
Yeah.
Everybody, you think legs go up and stirrup and push out a baby. So we don't have to do that, though.
Yeah.
And usually they are very much so like, okay, yeah, fine, whatever.
Now, if you have,
call me when it's time for delivery.
If there are some risk factors that you may have that would be more ideal to deliver in a certain position, if you are faced with some of those, like a big baby or something like that, then they may ask that you be in a certain position, so that way if something does go astray, we can help with that. But other than that, they're really good about letting you move around, but you just have to ask.
Just make sure you're communicating that.
Yeah, that's the biggest thing.
I mean, if you have the idea, just say it, and if we can't accommodate it, then we can explain to you why it's not a good idea. Or, I mean, we want to meet you where you want to be, but also keep you and baby safe.
I think that's
Yeah, sure.
So obviously some of the positions, if you do have an epidural, they won't work. But so I've heard that once you have an epidural, the nurses are like, you're not moving. Is that not
No.
true?
So you should be moving.
We want
now.
you to
You're
move.
not going to be up and moving. So we don't do walking epidurals.
Okay.
Some facilities do that. We do not do walking epidurals here. But once you get your epidural, your nurses are going to be turning you usually about every 30 minutes.
Okay, I was worried about them not doing that.
Yeah, no.
And if they don't, just be like, hey, I'm uncomfortable. Do you mind moving me?
Like, I'm ready to be moved now.
Hey, can you move me? Hey, I want to
Same
rotate.
thing with the labor support tools up here. Like if they're not bringing this and you want to try it, like, hey, can I get that peanut ball or can I try the cub? Just communicating with that nurse. Just telling them, hey, I want to try this. And you might try it and you might be like, this ain't for me. Let's try something else.
The peanut ball was not for Carmen at one point in time. I was like, y'all can have this. I'm not doing it.
The peanut ball is really hard when you don't have an epidural. It puts a lot of pressure on you and the pain is just intensified.
I was like, nah.
Miss, no epidural. That's what she was feeling.
I was like, I can't do that.
They're fantastic for epidurals, though.
I thought it was a great idea at first, but
The peanut ball is probably my favorite tool
Yes.
for an epidural because it helps open your pelvis. you know, me and my pelvis over here, helps open that pelvis up and helps that baby to get down into your pelvis nice and low, help that baby rotate. We've seen a shortening of labor with peanut balls after you get an epidural, and also it decreases your pushing time. We find that too. So that's like my favorite tool with an epidural. Like Carmen had mentioned before, the cub can also be used with an epidural, especially if you have that baby that's facing up instead of facing, you know, the back. To get that baby to flip, we really like that as well. So just because you have an epidural doesn't mean we can't use these tools. And we really want you moving with an epidural. Okay?
Moving is your friend in labor,
Joanna?
epiduralized or not.
Joanna mentioned her favorite labor tool, and I'm going to talk about my favorite labor tool, one of my favorite labor tools, and I'm going to get lots of eye rolls, and that's fine because I do it all the time. Get eye rolls, I'm okay with it. The mirror.
Oh, I love
the mirror is one of my oh, look at you. Okay, I'm going to pitch it, though. Let me tell you why. If you have an epidural, sometimes you get a really dense epidural, right? You can't feel nothing, not a thing. And pushing is hard. Getting a baby to come through a pelvis is not easy. Baby through little hole, not easy, okay? So, if you're not feeling things and you can see things, it really helps you be more efficient. So, if you're pushing and you're pushed like this and it's not moving the baby, we could push for 4 hours like this and your baby not come through your pelvis. Or if I push like this, I see that baby's head move and I can actually see something happening. Why would you push for 4 hours like this when you can push for an hour and a half like this and actually have a baby, right? So if your baby is moving and it's coming down and doing great and you feel all the things and it's wonderful, fine. You don't need my mirror. You can roll your eyes at me, that kind of thing. However, if you're having a hard time pushing, if you're having a hard time feeling, just try it. I promise it don't look like that when you get done, like it goes back to normal, all the things, just focus on your baby's head moving. That's all you need to look at in that mirror. What do I do that makes that baby's head move? And I want to do that over and over and over and over again so I can have my sweet nugget, okay? That's my pitch on the mirror.
At the end of the day, your nurse is going to see the progress you're making, and you're going to feel like you are giving it your all, and we're going to be like, nope, you're not doing, that's not right. I need you to push harder. I need you to do it this way. But visualizing that movement for yourself is like, oh, that's it.
That makes
okay,
sense.
now I know what they're talking about.
I
They
see
can actually
it.
tell when I'm not putting all the effort or pushing in the correct way. So, and it's very hard to explain to someone how you need to be pushing. So, I'm with Carmen. I love the mirror.
I love the mirror.
Love it.
All right.
We kind of skipped
One
pain medicine.
other labor tool that we have is the tub. So we have tubs in all of our rooms but two. We don't actually do like the birth in the tub, but you can labor up until birth. So it's really nice to be able to get in that water. It kind of gets the weight of your belly kind of off. It kind of helps with contractions. I've found with some of my births, if I can get down in that water, it helps those contractions. Transition is a really nice time to get into the tub. So that's going from that 7, 8, 9 centimeter time frame. That's the most intense part of labor. And sometimes people who are trying to go without an epidural, they're like, I just need a little something, something. And that tub can really be a nice little something, something to kind of get you over that hump of the most intense part of labor.
The reason we don't do tub births is just for safety reasons. It's not that we don't want to do tub births. We would all be like, heck yeah, let's deliver in a tub. But the tubs are where we can't safely get to you. So that's the reason we don't actually deliver in the tub, because we need to be able to help you or help your baby in case of emergency.
They're
And
like in the bathrooms where we just can't get to you and access you on all sides of it.
So it's not that we don't like tub births. Don't think that, because we would be all about it if we could do it safely.
And sometimes
Sometimes it happens.
just happen.
And usually, if things are happening, then you're not at risk for those things that are emergencies that we would need to be getting to you. So, like if you're like, oh my God, I'm fixing to deliver in the tub, and those nurses said that it's not safe. Usually, if it's coming and it's coming, then it's not a problem. You can usually deliver in the tub just fine. The problem is when that baby's not coming and we need to be able to help you get that baby out, then it's a little bit tough in the tub.
You'll
Make sense?
notice that some of the home births where they use the tubs, it's a round tub in the middle of a room you can access from all points to the mom. So that's why we don't do it.
Yeah.
But if we could get those.
Yeah. Maybe
Yes,
one day.
Maybe one day.
Pain medicine?
We got 5 minutes till Q&A, so let's
Um,
run through that.
So
sections.
pain medicine, we offer IV pain medication if that is something that you need. Kind of takes the edge off. Lasts for about an hour. You can have more doses of that. Epidurals, I'm sure all of you've kind of heard about that. We have a fantastic team of CRNAs that are just ours. I joke and say they can put an epidural in the dark with their hands tied behind their back. They're amazing. So like I said, you have to get a little bit of fluid before the epidural. So communicate with your nurse when you think that you may want an epidural. I don't want you like about to jump out the window hurting so bad before you tell me, because you will have to get some lab work back, and we're going to have to give you a little bit of fluid before we do the epidural placement. And then our CRNA comes in. You're able to have one person at the bedside with you during the procedure, and you get your epidural. Feels pretty good.
I will say, if you are, when you're thinking about birth plan and exactly what you want, you might come into this and go, I don't want an epidural. I don't want any type of pain medicine. I don't even want IV pain medicine, whatever that is. Come in with that idea of what you want, but have that backup plan and have that conversation with your support person, because if you have never done this before, you might get to a point where you're like, ooh, actually, no, I want something now. Some people, I like to tell my patients, if you tell me you don't want medication, I'm not going to offer you that medication. So I need to know, you and your partner need to have a code word, have that discussion, so that when you're like, okay, no, I'm ready for something, then I will go, okay, no, this is actually what she wants. Just have that conversation beforehand, though, so that everybody is on the same page and we're getting you what you need.
I like the idea of a code word, because I don't want you dying, not having what you need, but then you can also say, hey, this is what she actually wants.
Yeah.
Is there a time when it's too late to get an epidural?
When the baby's coming.
Yeah, like the baby's coming out.
As long as you can sit still. That's
Sit up
the
and sit
only,
still.
and it maybe 2 minutes of sitting still. It's not very long that you got to sit still.
It
but
does take about 20 minutes to 30 minutes after you get it placed for it to take its full effect. So sometimes you're going to have a baby sooner than that 30 minutes, and
the pain's going to be over.
Pain's
Once you
gonna
have
be
your baby,
over.
you're okay.
I mean,
So-
we're going to still try. I mean, but it might not work for your delivery. It might work for your recovery, but you might not get any pain relief for your delivery. But there's not at 7 centimeters, you can't get an epidural anymore. Because we've had women at 5 centimeters not be able to get it. Like if you're born in labor and things are just going too fast, it's not going to have time to work, and you're going to get out of pain in just a second anyway. Does that make sense? But then we've also had people be complete and get them at complete and take a nap and all the things after that too. So
Yes.
But
But if you want an epidural, your nurse is going to do everything they can to make sure that happens before you deliver.
We're boring her.
Teresa says, I'm tired of this class. C-sections, again, there's kind of two types. You're either going to be scheduled for a C-section, or you're going to come in labor and then end up having a C-section. They kind of look the same, I'm going to be honest, in the sense of when you come in for a C-section, we're going to go to the labor and delivery space. You're going to get prepped, you're going to get your IV, they're going to shape and watch your belly, all of that kind of stuff. Your family can be in there with you. Now, when you get ready to go back to the OR, we're going to take just you to the OR, okay? We're going to take you back there. We're going to get you set up. We're going to do that. Usually we do a spinal in the OR because it's a heavier block. It's a better block for C-sections. They go in, put the medicine in, take the needle out. You're all done. You get nice and numb. It is normal to be nauseated, okay? Unfortunately, that is a side effect of a spinal or an epidural. And what that is it's a drop in your blood pressure that's caused you to get nauseated, okay? There are medicines that we can give you, but unfortunately, sometimes it just is what it is, okay? With those, I mean, you throw up in labor anyway, but then you have this on top of it. So know that that is normal to feel that in the OR or even after an epidural. It's also normal with the spinal to feel like you're short of breath and you can't breathe. You're going to be breathing fine. It's fine. But what happens is that your diaphragm gets a little bit numb from the medicine, and then it makes you feel like you're not breathing, but you really are breathing, but you can't feel your diaphragm, so you wig out. It's normal. Just know that it happens. Communicate that with the CRNA, okay? They're going to reassure you that you're doing fine, okay? It's also normal for you to feel tugging, pulling, all of those sensations, but it shouldn't be sharp and painful, okay? So just because we do the spinal doesn't mean you're going to not feel anything at all, okay? You're going to feel all of that movement, but it shouldn't be sharp and painful, okay? If you're feeling sharp and painful, you need to tell somebody, okay? Now, if you are laboring and you have an epidural, what we're going to do is we're going to give you lots of medicine through your epidural catheter to get you nice and numb for that C-section. So again, you shouldn't be feeling anything. There are a couple of circumstances where it is an emergency. Our preferred, believe it or not, method is either spinals or epidurals for C-sections. We don't like to put people under general anesthesia because that's not what's best for you and your baby. But there are a couple of circumstances where that may happen, and in that circumstance, unfortunately, your support person won't be able to be in the room with you for the C-section, but we'll have them in the recovery room ready to go when the baby comes out. But again, your nurse will talk to you about that ahead of time, all of those kind of things, if that was the emergency situation that we were placed in. Now, once the baby comes out in the OR, it's going to go straight to the warmer, which is in the room with you, because we want to dry that baby off. The OR's cold, they're wet. We want to dry that baby off, and then the baby's going to come back to you, and you're going to have that time, you and your family together. We take better pictures in the OR, so make sure you bring your camera.
Real good pictures.
Those are the best pictures. So you're gonna have really good pictures in the OR, so bring your camera. After the surgery, closer to the end of the surgery when we're getting wrapped up, we're gonna take your support person and the baby to the recovery room. We're gonna do weights and measurements while they're cleaning you up. That way when you get to the recovery room, you're ready to go skin to skin with that baby as soon as we can, okay? While the support person, like I said earlier, is in the recovery room, they can do skin to skin if that's something that they want to do or that y'all agree on kind of thing until you get there. And then we'll put that baby skin to skin. In the recovery room, in the PACU, you'll stay for about an hour before you go up to the family care unit, and then we'll move you and your family up after that. Real quick, and then we're gonna ask questions. We do have the only level 3 NICU. All of our staff, nursing staff in the Women's Pavilion are trained on NRP, or neonatal resuscitation. Just because NICU comes to your delivery does not mean your baby is automatically going to have to go to the NICU. So don't freak out if a team comes in there. It doesn't necessarily mean that they're going to have to go, okay? There are some things that ahead of time we ask them to come for if you have some risk factors. Usually if they come and the baby's crying, they're like, bye, see y'all later, we don't need to be here. But they're here if we need them. We have literally a button on the wall. If there's an emergency, we mash it. You're gonna have so many people in your room, you don't even gonna know what's going on kind of deal. Once the baby is stabilized, if the baby's fine, they're gonna put it right back skin to skin with you. If for some reason the baby is needing to go have more fun with our friends in the NICU, then they will do all of the stabilization in your room. They're not just going to be like, your baby's not doing well, we're going to see y'all in 2 hours when you're done. They're going to do all the things in the room, get that baby stable, so that way you're there, you can see it. Then they'll take your support person and the baby to the NICU and admit the baby into the NICU while we finish taking care of you. And then as soon as you are medically stable, we will take you over to the NICU so you can be with your baby. Quick pitch on the NICU kind of deal. They're great over there. Have a lot of support if you have to end up in that situation. I think that's all that we had planned, but we have a question and answer. We have about 10 minutes or so. We can answer questions.
Could you talk about the pulsating umbilical cord?
Yeah, great point. So that's pretty standard for us. If your baby comes out doing great, we're gonna let that baby come right up on your chest, and then we're gonna leave the cord attached. until it's done pulsating. At that point, then that's when we can, cut the cord. If you, we recommend you kind of have in mind who you want cutting the cord. A lot of times the support person will do that, and the doctor will kind of walk them through that part of it. But yeah, that's one of the standard things that kind of everybody gets is that delayed cord clamping.
I pass out easily with the cord cutting.
Yeah.
That's something that would trigger me probably.
You could sit down in a chair.
We might have a chair right there for you.
Yeah.
Just give your nurse the heads up.
Give your
Yeah.
nurse the heads up that you like to misbehave.
And also,
Yep, at the very beginning.
At the very
seriously,
Yes, for real.
eat. A lot of times dads are like, oh, I feel bad because my wife isn't wanting to eat right now, or eat. Okay, because I find a lot of times dads will pass out when they have not had food and drink.
Yeah.
So bring a snack bag and we'll give you a chair.
Yes.
I love that you know that though.
Is my support person allowed while in the room with me while I'm having the epidural?
Yes, in the epidural space, yes. They'll be in there with that.
Yep.
One person in there. In the OR, the reason we don't do it, we get the spinal and we get you nice and clean and sterile and all of that kind of stuff, and we want to make sure that works. So that's the reason that the dad or support person hangs back for that procedure. And I didn't mention, as soon as we get you nice and numb and get you laid down, then we get your family members in there. You're not gonna it's not very long without them, but we just wanna make sure that we can get you nice and numb and comfortable and limit the amount of germs kind of thing beforehand. Does that make sense? Great question.
You mentioned that there's, I don't think this is working. You mentioned that there's in the first 48 hours, like a list of regular procedures that you guys do. Is there like a printed list somewhere of what all happens to baby in the first 48 hours, like so we can see all the things that are gonna happen?
Yeah, so we can speak to kind of what happens in labor and delivery. There's another breakout session all about postpartum right after this. But in labor and delivery, the standard things that we do a hepatitis B vaccine. We do the vitamin K shot, and then erythromycin eye ointment. That's are the things that are done in labor and delivery. If you don't want those things, just communicate that, no problem. We do, weights and measurements on the baby, so how long the baby is, how much does it weigh, and we do a full head-to-toe assessment of the baby. That's also done in labor and delivery. All that will be done at your bedside, so right there for you.
The rest of the stuff weren't.
Correct.
After the first
Yes,
hour.
after
Yes.
that first
Correct.
The rest of the stuff we don't know about.
Now that I've never done this before.
That's okay.
That's okay.
So I know my parents, or at least my mother, and my mother-in-law, at least up until the time of active pushing, are gonna wanna be in there. That's
Yeah.
Great
That's
question.
Totally
Yeah.
fine. Yep.
We allow 5. We have an unlimited visitor policy, meaning that you can have as many people at TMH to
Come
see
and
you
go as you
come and go
please.
as you want. However, for safety reasons, we do ask that you limit the people at your bedside to 4 to 5, just because between our stuff and your stuff and their stuff and medical equipment, it gets small, and I need to be able to take care of you in case of an emergency. And so many more people than that, it gets where it's unsafe kind of deal. So they can switch in and out as much as they want, but we do limit that to 4 to 5 people. In the OR, it will be your one support person. Your one support person will go with you to the recovery room. You can't switch in and out in the recovery room, but you'll only be there for about an hour. Then when you get up to family care or mother baby, your visitor can go back to the 4 to 5 kind of thing, switching in and out kind of deal.
We were considering the option of getting a doula, but it kind of sounds like you guys do all the stuff that a doula does.
A doula is still great.
That's a wonderful option. It's somebody else that is a part of your care team where you can have that conversation. They can help advocate for you. They can help you advocate for yourself. They still are a great tool.
We see them all the time.
Doulas a lot of times help in the postpartum phase, help with when you go home, those kind of things. People think about doulas and they think about only labor and delivery, but a lot of times their services extend outside of labor and delivery too, which when you're at home with a newborn and you don't know what to do and you just can someone please help, that would be a good resource too.
One of the questions I had was, one of the things that they do is the pressure points.
Yep.
Are you guys trained in that? Do you know?
So we do a lot of like counter pressure. That can be really helpful, especially if you're having that back labor. So our nurses are kind of trained on those tricks too, on kind of what to do with that. But like I said, do you have to have a doula? No, you do not. But if you want one, we welcome them onto the team. They're another player on the team with us.
And they're a really good tool to have.
All of the birthing tools, will they just be in your room automatically, or do you need to request them?
You'll have to request. If there's a certain something, I mean, your nurse may just bring it in without you. And she's gonna be like, all right, time for the peanut ball. But like, if there's something specific, just because they take up a bunch of room, we have them in a storage closet. Yeah.
Do all of them have tubs?
Oh, all but 2.
Yep.
And the 2 that don't have tub have handicap accessible showers. So please let your nurse know if that is something that you want ahead of time, because it never feels like we put you in the room that you don't have a tub when you want a tub, even though we only have 2.
Is the signal from the belly Bluetooth, is that at all like harmful to the baby?
No. Nope. There is a little bit of a delay, just like normal Bluetooth kind of thing. So, but your nurses know all about that, but there's no.
Meaning like you may feel the contraction and then you see it on the screen
Right.
a second later.
Yeah.
Does that make sense?
Like there's just a little bit of a lag, but that's normal. But it's no harm to
anything.
the baby. It's just like normal Bluetooth.
I never heard this question, so I'm sorry.
No, that's what we're here for.
So the first hour is skin to skin with baby, but if I need anything to be fixed, does that happen also while I'm having skin to skin?
Yeah.
Yeah.
It actually is wonderful, because that helps you focus on baby and not what's going on down there. And if you had an epidural, a lot of times you don't even really know what's going on exactly. And if you didn't have an epidural, we do use what we call lidocaine to help numb that area up before we start sewing and putting things back together. Lidocaine sucks for a few seconds, just like when you go to the dentist and they inject the lidocaine into your jaw. It hurts for just that second and then it gets numb. It's the same thing when we're doing a repair. But it's usually a good distraction to have that baby. But if you're like, I'm overwhelmed, this is too much, I got too much going on, or you're not stable, then we will gladly let your partner do skin to skin or wrap the baby up, and then as soon as you get stable, we'll put the baby back skin to skin. Just because it doesn't go skin to skin in the first 5 minutes, first 3 minutes, doesn't mean that you can't do it at minute 15 or minute 22 or minute whenever you get stable or you feel like it, kind of thing. Good question.
Great question.
Oh, you said earlier there was like, you can have like a heavy epidural where you don't feel anything at all. Can you also get like a light epidural where you sort of?
Yeah, and guess who controls that? You.
Okay.
Everybody is different.
Yeah, your body's different.
No, you can't control it either. Like,
You
but
can't request like, I want to try a light.
you can talk to the CRNAs, but at the end of the day, the way your body reacts to it is crazy. Like, and really,
Because they don't do like light epidurals. Like in places where they do walking epidurals, it's a different medication that's used. Here, it's everybody's getting the exact same medication across the board. It's the dose is based on how tall you are, and then however your body responds to it is how that works. Like they can't adjust like the concentration of the medication. You know what I mean?
and it's wildly different. You know, you get an epidural with your first baby, which is going to be different than when you get an epidural with your second baby. Some of them take great, some of them take not so good. I usually tell women to expect 75% pain relief with an epidural. You're not going to get out of this free. It's no, it's not all the way. Very rarely do you land in the category where you don't feel anything at all. My friend Fado had one of those. She was laughing. I was like, "You're gonna have a baby." Just
they kept telling me to stop laughing. I'm like, why? Because the baby's coming out.
I was like, we got to get the doctor here, and then you can laugh after he comes. But,
Also, sometimes I like to say, if you come in triage like rip roaring labor, and we get you your epidural, sometimes it don't have enough time to like catch up. So it depends on how fast your body's moving with your labor as well.
There's a lot of different factors. So it's really hard to say whether or not you're going to get one that's really heavy or not heavy or all of that kind of stuff. Now, if you get one that's not heavy and it's not working great, we can give you extra medicine through it to help numb you up. But at the end of the day, a lot of times 75% is where we can get you kind of thing.
All right, we have time for one more question. Go ahead.
I was just going to say, if you're progressing through labor and then you start to stall, do you have the option to refuse both Pitocin and the rupture?
Absolutely.
You can refuse anything you want.
Absolutely. Your body, you're the boss. You tell us
what you're doing, what you're not doing, what you want, what you're comfortable with. It is very, very important that you all have the autonomy to do that, okay? So whatever you want to do, just make sure you communicate that.
Yeah,
and those are things to think about before you come in. What are you comfortable with, okay?
And talking to your provider about what they are comfortable with and what you're comfortable with, so that way y'all can be on the same plan as well, too. You know, like certain risk factors and all of that kind of stuff. You just want to all, the more things you can align ahead of time on, the better the experience will be. Labor is hard. I'm going to end with this. Labor is hard. Sometimes it sucks really bad. If it does not go just like you planned it, please know that that's normal and talk to someone, because there's so many factors and so many things, and you have a whole nother human that's controlling majority of it, let's be real. But at the end of the day, we want it to be as best for you as it can be. So if things don't go exactly the way you had laid them out, like talk to someone so that way we can help you cope and be okay and try to make it as much that as we can, but still be safe and take care of your baby. Does that make sense? Because it's really hard when you have your mind set on something and you come in and you're like, this is the way it's got to be, this is how it's going to be, and then you get this little curveball. It kind of is like, ooh, I don't know. Now I don't know how to handle this, and I've got all of these emotions and all these hormones, and we're really good at helping you when that curveball comes. Like, I'm really good at helping talk people off the ledge. Like, but I've been there. I know what it's like. So talk to your nurses so we can help advocate for you. We're going to be around.
Thank you, guys.
Yeah. So if you have any more questions that didn't get answered, feel free to stop one of us.
We also do tours on Thursday of like labor and delivery and the postpartum unit. So certainly feel free to sign up for one of those.
Yeah.
You can sign up on the website and ask questions there. There's also a email address you can send questions to, and we're going to be around down here in the Mushton Center if you guys have any questions, okay?
Thank you.
Thank y'all for coming.
Thank you for coming. Hopefully it was helpful.